So we actually have Dr. Moser, who's actually my oncologist from Scottsdale, Arizona. He is going to be joining us virtually, so we're going to pull him up soon. And then we have Dr. McKean, who's here from Nashville. And we have Dr. Is it Dr. Sang? Is it Sanger? Dr. Sanger. And they are both here from Nashville. They're going to be joining us on the stage in just a few minutes. I'm just stuck. Here we go. So let me just briefly introduce these guys to you. Dr. Moser is a medical oncologist who specializes in phase 1 clinical trials and drug development and cutaneous malignancies. He leads the melanoma program at HonorHealth Research Institute, and he runs one of the only programs in Arizona that's dedicated to uveal melanoma. Dr. Meredith McKean, who's joining me on stage now, received her bachelor's from Iowa State University and was as a promising athlete, she ran cross country and track. She continued earning her education and earned a degree in a master's of public health. And during medical school, her research in heart failure and heart transplant focused on building a tissue bank for proteins predictive of patient survival. Following that point, she eventually studied at MD. She completed her fellowship in Hematology-Oncology at MD Anderson, and she studied the biomarkers for immune checkpoint inhibitors in metastatic melanoma, which earned her an American Society of Clinical Oncology Young Investigator Award. She now serves as the Associate Director for the Melanoma and Skin Cancer Research Program at the Sarah Cannon Research Institute of Tennessee Oncology. We also have joining us Dr. Sanger. And Dr. Sanger, if it's okay, can I have you introduce yourself just briefly? I unfortunately don't have your bio on here and I missed it. So I just wanted to let you tell us a little about yourself. Check the light. Do you see a green light? Yeah. Shake it. All right, now talk.
How's that? Oh, good, thank you. Good morning. My name is Maureen Sanger. I'm a psychologist with Tennessee Oncology, so I counsel cancer patients and survivors. I did my graduate work at Vanderbilt University, went on to MD Anderson for a couple years for some additional training, and have been back in Nashville doing various things over the course of my career. Before joining Tennessee Oncology, I was an assistant professor of pediatrics at Vanderbilt, where I worked with the cancer and sickle cell disease program. So that's me in a nutshell. I'm happy to be with you this morning. Thanks.
Well, thank you so much. Thank you for joining us. We're glad to have both of you, and we're glad to go ahead and let's bring Dr. Moser up so they can get started. And as far as I'm remembering, Dr. Moser is actually going to be presenting first to talk to you guys about uveal melanoma, metastatic spread, and just kind of like, okay, what can we talk about here? Obviously, this is a big topic. So we're just going to have technology join us. Hello, Dr. Moser.
Can you hear me?
Me. Oh, there we go. So we can hear you.
Okay, perfect. Okay, so hi everyone. Sorry, my plans changed and I'm no longer able to be there in person. Perfect. So I don't know, are we able to pull up the slides? I'm only seeing me, so I don't know if the slides are up or not.
Not yet. Give it just a sec, Dr. Moser.
Perfect. Just let me know. Yeah, so while they're being pulled up, so I think, you know, the next two talks are going to be pretty casual. Both Dr. McKean and myself are going to kind of tag team everything. So it's going to be more of a group discussion. So if there's any questions for me or Dr. McKean, just let us know. And so that would be great. Okay, it looks like the slides are up. So, you know, we're going to start today by talking about how to navigate a diagnosis of metastatic uveal melanoma. So we can go to the next slide. Great. So, you know, anytime you get a diagnosis of metastatic cancer, it's hard. And there's a lot of information, and there's a lot of information online, and people will give you lots of information. So I just wanted to start with some general comments about, you know, what are the things to think about when, you know, you're diagnosed or there's a concern you may have metastatic uveal melanoma. The first thing is use the patient advocacy groups. You know, the information that a Cure site has that they put together. The Melanoma Research Foundation also has information about uveal melanoma. A lot of this information is patient-facing, and they're really good resources. I know a Cure Insight has a weekly Zoom call where you can log in from anywhere in the United States, patients or friends of patients or family members, and kind of jump on a call and talk about, questions, concerns with people. And really, a lot of my patients have found this information and this interaction really, really beneficial. So the number one thing is use the patient advocacy groups. It's good information, and they're just a really supportive group of people. The other thing that you want to do is find or coordinate your care with a medical oncologist who has some expertise in uveal melanoma. So, medical oncology has really blown up over the years. It used to be an oncologist could know everything. Now it's when you're an oncologist and you see all tumor types, we're learning so much and getting so much information, which is great for cancer care. It means it's really hard to keep up on stuff, especially for rare tumors like uveal melanoma. And so really make sure you get your care with someone who knows uveal melanoma, or have someone involved in your care. And that could be a melanoma specialist who doesn't necessarily say they're a uveal melanoma specialist, but they see enough melanomas and uveal melanomas to understand. Or that could be going around to a uveal melanoma center and just having them work closely with your local oncologist just to kind of help guide the care. The next point I want to make is third and second opinions are okay. And I think we see a lot of patients go around and get different opinions, but beware of the fact that you're probably going to get different opinions. So one of the things with uveal melanoma is that it's so rare, we don't have as much definitive answers as we do for other tumors. It is not, this is the absolute best treatment for this setting, and this one we know is less effective. A lot of times it's, well, this is what we think is the best, because we don't have a lot of data directly comparing each other. So if you want to go get more information, do it. More minds are better. But if you're someone who is hoping to get one answer from 3 different people to make you feel better, realize that may not happen. And that's just because we don't actually have all of that data to know what is the best number 1 thing, number 2 thing. And so just I'm glad we have the clinical psychologist here, because this can be really traumatizing for patients. And so that's just something I want to put on people's radar. The other thing I always tell people is if your provider is concerned you have metastatic uveal melanoma, the way we always confirm cancer is by doing a biopsy. And I always tell people, send genomic testing from the biopsy from diagnosis. So there's 2 ways of doing genetic tests. You can test the tumor, which is seeing what DNA or other molecular changes are in the tumor, or you can test the person to say, what are your genetics? And for uveal melanoma now, we need to do both. So whenever we have cancers that have limited treatment options, we always like to send genomic testing on the tumor, because it may give us different ways to treat patients. And I tell people, this is kind of a fishing expedition. Sometimes we find things that changes the management, sometimes we don't. But really, we don't know until we look. And so I always tell people, go ahead, send the genomic testing on the first biopsy. That way we get as much information early on to really help clarify the treatment plan and how we can move forward. The other thing we need to do besides testing the tumor is testing you as the person. And that's, testing for germline HLA testing. So germline means we're testing you and not the cancer. And this is important for one of the treatment options that I'll talk a little bit about, and Dr. McKean will talk a little more about next hour, Kimmtrak or tebentafusp. This is an immune therapy that's specifically designed to only work with one HLA type. And so we need to know if the patient has that HLA type, because if they don't, there's no point in treating with the drug, because it's designed not necessarily to work. And, we get a lot of questions about what is my HLA type? And what I like to tell people is this is basically a fancy blood type. So ABO, the same blood types we have that help guide what type of blood we can give you, this is basically the blood type for organs. So when we do organ transplants and say, can we give someone this kidney? We have to match the HLA blood type, just like we do the ABO for blood. So really, it's just a blood type for your organs. Next slide. So when someone gets metastatic uveal melanoma, as we all are well aware, greater than 90% of the time, the cancer shows up in the liver. And for most patients, this may be the initial only site of disease, or it could be the site of the greatest burden. And so this is why after plaque therapy or removing the eye, we tend to follow patients with imaging that gets really good look at the liver. And that's typically MRI. PET scan gets a pretty good look too, but both MRI and PET scan tend to give us better images of the liver than just a CT alone. When we see someone in clinic that just has disease in one area, such as the liver, we always ask ourselves, could we try a local therapy? So something that we give to part of the body rather than all over the body, and see if that can help. And for uveal melanoma, those local therapies are typically liver-directed therapies. And for some patients, these are very reasonable options. Next slide. So this is one of the areas that we don't have a lot of information. So there really have never been great studies comparing liver-directed therapies to systemic therapies in uveal melanoma, especially with the newer systemic therapies that are commonly used for uveal melanoma or approved. There was a meta-analysis that was performed that suggested maybe focusing treatments on the liver does improve survival and benefit, but it's unknown if that's just by patient selection, because obviously patients who only have liver or disease in one spot may do better inherently than people who have disease in 6 or 7 slots. And then, like I said, this study was done far beyond or far before we had these new immune therapies like Opdivo and Yervoy, which is commonly used for uveal melanoma, or it's Kimmtrak, which is now approved for people with the right HLA type. And so we still use liver-directed therapies a lot, but this is really one of those areas, I think, and we can get Dr. McKean's thoughts in the discussion after we finish up our short slide set on this, where we don't really know what is better, liver-directed therapy or systemic therapy. And then if we do liver-directed therapy, what is the best liver-directed therapy? We don't have a lot of data comparing these things head to head. Next slide. So what are the types of liver-directed therapies? So there's kind of 2 things I like to think about. There's transarterial embolization, where interventional radiology goes in and basically blocks the arteries that go to the liver. The liver is very unique in the fact that the normal liver itself actually gets its blood from the portal vein, but cancers within the liver get its blood from the hepatic artery. So you can actually go in there, go into someone's body, cut off the hepatic arteries, and really not have much damage to the liver itself, only cancers growing in there. And that's really the basis for these arterial embolizations. So there's a lot of different embolizations that you can do, and really it comes down to what do you put in the artery before you block it. So we have chemoembolization, where they can give chemotherapy into the artery, thinking that the chemotherapy will get directly to the tumor, and then you block the artery so there's no more blood flow. You can drop in radioactive beads, and this is the typical yttrium or Y90 or radioembolization before you block the artery and prevent more blood flow. And then you can do immunoembolization, where we give different cytokines through the artery, thinking they get directly to the tumor and then cut off the blood supply. Again, none of these have ever been compared head to head in a randomized trial, so we don't actually know which ones are best. There may be different reasons based on side effect profiles or how fast we think they work that we would recommend one or the other. But otherwise, we don't have good information to say this is the clear best option, this one's the clear worst option. I think an exciting type of liver-directed therapy that's going to be coming out, or that is out a little bit and hopefully is more accessible soon, is percutaneous hepatic artery perfusion, or sorry, percutaneous hepatic perfusion. This is based on a clinical trial that's been published and is currently being offered as an expanded access, as an early access, which means they're allowing patients to get this before FDA approval. And this is currently only being offered at Moffitt Cancer Center and Duke Cancer Center. I think I have a picture of this on the next slide. Perfect. So what this is it's similar to the embolizations where we need an interventional radiologist. And what they do is they go into the arteries, and instead of going to they go into the blood vessels. And instead of going to the arteries that feed the liver, they actually go into the IVC and put a machine in there that blocks the circulation from the liver. So basically, we isolate the liver and put it on bypass, similar to what you would do if you had a heart transplant or a major cardiac surgery. And so they basically turn your body into two different circulations. One, your body, which circulates blood everywhere except the liver, and then circulation of just the liver and the machine outside, which oxygenates it. They then circulate high doses of chemotherapy through the liver. So chemotherapy gets high doses everywhere in the liver, but not the rest of the body. They then stop the infusion, reconnect the circulation to the liver back to that of everywhere else of the body, and then it's done. They've shown really exciting results with this. I think they've reported response rates in liver anywhere from 30 to 50%. We're still waiting for the data to mature, but I think, and again, we'll get Dr. McKean's version on this. I think based on the data I've seen, although it's never been compared head to head, I get the sense this might be one of the more effective liver-directed therapies that are out there. But again, there's no data to definitively say that. That's just based on comparing what's published with something else, because they haven't been compared head to head. So we talked a little bit about the liver-directed therapies that we could do. I didn't mention radiation. Radiation is always an option. If there's just one or two spots, we can always do spot treatment with radiation. Most of the time, there's more than one or two slots, which is why, or more than one or two spots in the liver that need treatment, which is why we do the liver-directed therapies. But if there is a patient that just has one or two, maybe medium-sized spots that are kind of growing more than the others, we very easily can do just spot treatment with radiation too. That's a reasonable local therapy. So what about the systemic therapies? So there's a couple of things that are commonly used for the treatment of metastatic uveal melanoma. The first one is tebentafusp. So this is Kimmtrak, the only FDA-approved treatment for metastatic uveal melanoma. Again, it's only for patients with HLA-A0201, and this is that blood type for organ transplants. The big thing with tebentafusp is, you have to have that HLA type, and it's debated about how commonly patients actually have that. So for Caucasians, it's reported to be around 30 to 50% of patients. For non-Caucasians, it's actually much less. We rarely see this HLA type in non-Caucasian patients. And so unfortunately, although this is a great option, it's not an option for the majority of patients right now. Tebentafusp, we know, based on the randomized trials, extends survival by 6 months compared to pembrolizumab alone, and has a 10% chance of shrinking the tumors. Now, there's definitely benefit to this drug, even if the tumors don't shrink, which is why we see the extended survival. And I believe Dr. McKean will talk more about that in her talk. We commonly use nivolumab and ipilimumab for metastatic uveal melanoma. The degree of benefit for this drug is not quite as well known. There's been two single-armed trials of this drug, of this combination, and one retrospective, both which suggest that there's probably an 11 to 17% response rate. However, it very well could be that if we did a large randomized trial like we did with tebentafusp, we would see very similar response rates to tebentafusp. So I think a lot of us think that these are probably fairly equivalent in terms of their efficacy or their effectiveness. But again, they've never been compared head to head, so we don't know. And that will be a great discussion point to get Dr. McKean's thoughts, after the next couple slides. Pembrolizumab can also be given alone and has a 5% response rate. We know that from the trial with tebentafusp. And those are really the commonly used systemic treatments for uveal melanoma outside of clinical trials. Okay, so that concludes my short slide set. So now we're going to open the floor to discussion and questions, and then go from there.
Thank you, Dr. Moser. So Dr. McKean, Dr. Sanger, we're so glad you guys are here with us. Dr. McKean, do you have anything you want to add to what Dr. Moser presented, or do you want to just go straight to discussion?
Can you hear me? Yeah. No, great. I think Dr. Moser made a really great point at the beginning of this, is that there isn't one right treatment option. And so I think that can be something that's really challenging for patients to deal with. And I think Dr. Sanger can maybe comment on in her experience with patients with cancer. But I think this was a great high-level overview, and are ready to kind of jump into a discussion. That's what we're hoping with our sessions today, is to really just, this is just the foundation to discussing all these treatments.
Okay, awesome. So just as kind of housekeeping, as you guys talk, and if you guys want to share discussion, will you guys just make sure to pass the mic and just take a pause? Oh, you have a mic. Wonderful. I didn't see that you had a third. Great. Okay. Well, we are, obviously all of us are here. We want to understand more. And I think that we are going to have, just as you guys look around, you guys have question cards on your tables. I think that just as you guys can write questions, just let us know. Lauren in the room is going to be running around the tables, and she will pick up those question cards. Are you guys wanting to go ahead and just start taking questions from the audience, or do you want to talk amongst yourselves?
Well, maybe we can actually start with Dr. Sanger while we're gathering questions. I think Justin had started this discussion, but I think also with our conversations with a lot of patients, just from the time of initial diagnosis, the uncertainty of, we have pretty good molecular markers and things like that to be able to better understand patients' risk for metastasis. But Dr. Sanger, if you can just kind of take us through, what's your advice to patients at time of diagnosis, for patients that are on surveillance, or even for patients at time of metastatic disease? How do you help patients process that? It's a loaded question, I know.
Yeah, no easy answer to that, as you all know. That getting a diagnosis of melanoma, going through the process, one of the probably most challenging things a person can experience. And many people I talk to describe it kind of from an emotional standpoint as an emotional roller coaster. So there's the initial kind of spike in anxiety and fear and perhaps sadness. When you first find out about that diagnosis, there's a lot of anxiety between when you find out and when treatment starts, when you have decided on a plan. Then sometimes there's a period of adjustment as people go through their treatment, and then predictable spikes in fear, anxiety when it's time for scans, or when treatment stops being as effective as it once was, or when metastases develop. So I think that sense of emotional roller coaster describes really well the experience of many people when they're dealing with melanoma. I think two of the biggest challenges for folks dealing with cancer, and with this cancer in particular, since with uveal melanoma, as Dr. Moser, I think, described well, it's rare. There isn't a lot of data. There is a lot of uncertainty. And uncertainty is one of the biggest challenges of dealing with this cancer. Uncertainty about how the body's going to respond to treatment, what the course of treatment is going to look like. It's hard to plan, right, one's life when you're living with so much uncertainty. And the second, I think, is significant kind of psychological effect is the feeling of lack of control. So when there's much about dealing with cancer and going through treatment that's out of one's control, and that creates a lot of distress. So part of what I talk to people about as they go through cancer treatment is ways to manage uncertainty and ways to try and take control of the things that one can. So we can talk more about that if you all have questions, or if I can.
Yeah, I think that would be a really good thing to kind of go into a little more, if you guys are okay with that. Because like you said, one of the most challenging things is when you get a metastatic diagnosis, you're thrust straight back into the initial trauma that you experienced the first time you were diagnosed. And so that you've got kind of the resurfacing trauma, and then you've got everything else you're dealing with. It's so unknown. There is no right answer. And like you said, you're dealing with so much uncertainty. And when we have uncertainty, we want answers. We our brains need it and want it, and we don't know how to function without it. So I guess what would you say maybe would be some tools people could use in that case where they don't have a specific answer, their doctor's saying, well, like Dr. Moser said, maybe they get 3 opinions and they have 3 different options of, well, we could do this, we could do this, we could do this. How do you help them navigate that level of uncertainty with the kind of idea of, well, how do I make the right decision? And all of those pieces, I guess what would be some strategies for that?
Yeah, again, there's no easy answers to that. I think in terms of treatment, it's part of it maybe is reminding oneself that there's not a right answer or a wrong answer. I think so often we get caught up in kind of what's the right thing to do, or what's that one thing that's going to be the best. And oftentimes that's not clear. And so it's not right or wrong, it's or good or bad. It's talking to your healthcare providers, your specialists, your oncologist, gathering the information that you can, and then making the best decision that you can, knowing that none of us has the crystal ball, and so making the decision, committing to that, and trying not to look back. It's easy when 6 months or 12 months down the road to look back and say, maybe I should have done something different. But you make the best decision. That's what we all do. We gather information, we talk to the people that we can, we put our trust in our medical providers and make the best decision we can with the information we have. And that's all any of us can do. There are many aspects of dealing with this situation that's out of one's control, but there are almost always things that you do have control over, and so trying to shift your energy, your focus to those things is part of what helps with coping. So you have some control over how you take care of your body as you go through treatment, nourishing your body well, getting adequate rest, getting some physical activity, doing things that are relaxing or calming to kind of counter that anxiety that often shows up. Those are things that a person can do to take control of the things that they have control over. I think being mindful of one's emotions. So going through cancer evokes a whole lot of emotions: worry, fear, anger, guilt, frustration, sadness, grief. It's a lot of swirling emotions to deal with. And as humans, I think we're often inclined to try and not want to feel those difficult emotions, to buck up. How many times do you hear from people, oh, keep a positive attitude, and people want to see you, fight and be strong. And as if to say, don't pay attention to those difficult emotions that are there. But in reality, those difficult emotions are valid, they're significant. They're our body's way of telling us that we're going through something important, and it's helpful to listen to those feelings and acknowledge them, name them. There's an expression in the psychology world, which is name it to tame it. So when we acknowledge our emotions, when we name it, God, I'm feeling really sad right now, I'm feeling really scared. That helps to soften that emotion a bit, and when we acknowledge our emotions, when we express them in some way, whether it's through talking about it, whether it's through writing about it, whether it's through crying when we need to cry, there's benefit in acknowledging our emotions and releasing them, rather than trying to kind of power through and pretend that those things aren't there. I think one goal as a person goes through this is to accept the diagnosis and to accept that they're going through something really difficult. And sometimes I hear people say, well, acceptance means I'm giving up. And that's not what acceptance means. Acceptance means you're saying, this is what I'm dealing with, so this is what I have to focus on, versus trying to, having that struggle with, I wish it wasn't this way. I wish I could go back to before this diagnosis. I don't want to be dealing with this. That's a lot of energy into towards something that you can't change. And so acceptance is, okay, this is what I'm dealing with, so let's figure out how I can help myself physically, mentally, emotionally, as I walk this road. Those are some initial thoughts, strategies, things to think about. Again, happy to talk further, answer people's questions that they may have about those things.
I guess just kind of to follow up with what you were saying towards the end, how you mentioned like putting energy towards the things that you can't control versus the things you can. One of the things that I guess I'm curious to know is like, do you find it helpful for patients to focus on like the present? Because I think the tendency for most of us is to jump to the what ifs, and those what ifs are very far in advance. I think everyone's brain is different, but I know my brain and many other of your brains jump straight to, okay, I want all these answers, and what if this doesn't work, and what if that doesn't work, and what if this doesn't work? And you want to know, well, is there a plan for all of these potential scenarios that haven't happened yet? So would you say that like trying to stay focused on what's here in front of you instead of way down the line that hasn't even occurred yet is helpful for most patients?
Yes, absolutely, and thank you for bringing that up. That's an important point. So your mind works like my mind, works like most of our minds. Our minds are kind of tend to focus on the negative, the bad things that could happen, the what ifs. Right? How many times we say, oh, what if this really good thing happens? That's not what we usually what if about. It's what if this bad thing or scary thing happens. So that's the way our minds are wired, because our minds are designed to keep us safe. And so they're looking out for the threats, the danger. So we kind of have to work at reining that in sometimes. The what if can be useful at times if it leads to some problem solving. So like, what if this happens? Well, is there something I can do about that? Is there something that I can help myself with now about that? If so, great, do that. That's a way of taking control. But if the what ifs are, if you gotta get hooked on those what ifs, if they just kind of are on repeat in your head, and it doesn't really lead to any productive things that you can do about them, then yes, shifting to the present, I think is a really helpful strategy. It's what I call shifting from the what if to the what is. So what is it that I'm dealing with today? What is it that I know now? What is it that I can do something about today? And so if you find your mind being hijacked sometimes by those what ifs, to try and bring it back to the what is. What is it that I can do today? And also, when we're looking behind us at the past or looking forward to the future, we kind of miss out sometimes on the good things that happen in the present. And immersing ourselves in the present, what's going on today, how can I make the best of this day, is a useful way of coping.
Wonderful. I have one final question for Dr. Sanger that I think is very pertinent to this discussion, and then I kind of want to move on to some of our questions, if that's okay. So this one just asks, are there any resources for families coping with emotional and mental stress, caregiver support? So within your guys' practice, do you guys offer that to the patient family support? And I guess how would you suggest that patients find that in other avenues?
Yes, so yes, we are fortunate at Tennessee Oncology, where we do have a psychology team that offers counseling to individuals with cancer as well as to family members. So absolutely, caregivers or partners, spouses, friends, family of those who are going through cancer experience their own emotional responses and stress, and are deserving of support and counseling as well. So I would, finding a counselor can be really useful. There are, at in cancer centers, many do have counselors specializing in working with, dealing with the emotional impact of cancer. Here in Nashville, we also have a resource called Gilda's Club. For those of you who are perhaps from larger cities, you might have a Gilda's Club in your area. There's many of them across the country. They're also known as cancer support communities, but they offer a lot of support groups for people who are going through cancer, support groups not only for individuals with cancer, but often for family members as well. And that can be a really useful resource. There's a special kind of wisdom and support that comes from being with people who are going through what you're going through. And so support groups can be very helpful. There's support groups online as well. So for those of you who are on Facebook or who can access information over and activities over the internet, there are a lot of online support groups for individuals who are going through cancer. So that can be another good resource.
Thank you. I think that's just very good, pertinent information, and to recognize, again, to that control factor that we have ways to find this if we link up with the right resources. So I have a few kind of more medical questions for Dr. Moser and Dr. McKean, if that's okay if we move on to that. One of the questions is pertaining specifically to the percutaneous treatment that Dr. Moser presented on. And it just says, does the catheter remain for the duration of treatment, or is it reinserted each time? So kind of like a port, I think, for immunotherapy where they leave it. So Dr. McKean, Dr. Moser, do either of you want to weigh in on that?
Dr. Moser there. I believe it's with each treatment, it's placed and then removed.
I believe that as well, and I think it's just 1 or 2 treatments total, if I recall correctly.
Okay, so I think that covers that one. And just keep in mind, guys, we have a lot of questions. Some of them are a little bit more relevant to KIMTRAC, so if they are and I don't get those answered in this session, we will hold those for next session. Just keep in mind, anything relevant to KIMTRAC, we will discuss more in depth next session. Just what is your opinion on resection? That's not something that was ever really talked about in these options. That is something that is sometimes explored just because of the way that, like you said, medical oncology works. That tends to be a way of treating. So Dr. McKean, what's your opinion on that? And then we can go to Dr. Moser.
Yeah, I rarely recommend this. And that's generally because the metastatic disease, when it develops in the liver, it's very different than other cancers where patients may, a patient with colon cancer that is spread to the liver, they generally have kind of individual, larger tumors. But for uveal melanoma, it tends to be many smaller tumors, and that's why we watch with MRI, because we're watching for, just the smallest changes in the liver. And so the challenge can be is that oftentimes if a patient does go in for resection, when they go in, they actually see other smaller tumors. And so you're putting patients through a large procedure and may still be leaving active disease there. And so it's a good question. We get it often. It's a unique or specific patient that I would usually recommend it if they have kind of one larger tumor, scans have otherwise looked negative. Maybe it's an opportunity if you've had some disease control with the medication and there's just one persistent tumor. But oftentimes we can also pursue these with liver-directed treatments that might be easier to recover from.
Okay, thank you. I felt like that was helpful. So this is a question a little bit more about navigating clinical trials. And so we don't really need to go into major depth on this, but I guess if you guys as physicians want to kind of explain a little bit of the background of the process of how you walk a patient through selecting some of those like best course actions. And I think that you're going to kind of touch on this, but I think that we got to just keep in mind we're having a generalized discussion, and this is all very unique discussions that happen with someone's doctor. So they're going to give a general answer, but the answer is very different and unique for each patient.
And I'll jump in. We're actually going to discuss clinical trials at length the next session because we know it's such a big topic.
All right, well then stay tuned and hang out, and we will hold this question for later. All right, so let's just see if you guys can give a brief background on what's the expected life what is your life expectancy without treatment, and is there treatment available if if it like grows very fast, or no, if it goes to the lung first. Sorry, I can't read handwriting. So I guess what is the life expectancy stats that we know? Do you guys know those off the top of your head, or can you point us to that resource? And then we can cover the other question.
Dr. Moser wants to start with that one.
Yeah, I think, historically we've said that once uveal melanoma comes back and spreads, the survival is just about a year, just not a little bit over. Now, with all the screening and stuff we're doing, we're catching people earlier, and so that's probably longer now. I think on the KIMTRAC study, survival was about a year and a half for the control arm and just about 2 years for the KIMTRAC arm. So now I think most of us are saying 1.5 to 2 years on average. But I definitely have patients who beat that by many folds, and we definitely have patients who unfortunately don't make that, So it's really just based on, how fast your tumor is growing and, the specific information about the patient. Going to the question about what if it comes to the lung first, I've never been able to find great data on it. So I'd love to get Dr. McKean's experience. But my experience is that if it's not in the liver, patients tend to do better. They tend to live longer and their disease tends to be more indolent.
Yeah, I'd agree with that. And, I think the locations, though, doesn't specifically tie to, I've had some patients with lung metastases that they've been more indolent, and others that it has been more aggressive. I'll go back to the question about life expectancy. I think Dr. Moser's point about surveillance and catching it early, what I like to encourage patients to do is, our hope is that if we would find this disease, find it early when it, hopefully is kind of a lower volume, less disease, and that gives us the most time to pursue different treatment options, whether that's liver-directed, TEBI, if it's an option, clinical trials, and we're all hopeful we're going to change the historical survival expectations.
Okay, so why is it that you guys have the systemic data that we saw? We saw liver-directed therapies and some of the data for that, and then we saw the data for the systemic treatments. So why is it that the liver-directed therapies I guess have better outcomes in some ways than the systemic ones? Because we see the response rate, and I guess I'm just kind of curious, can we clarify some of that data of like, if it says a 9% response rate, what does that mean? What does a response rate mean really in this world?
Yeah, I can start with what does response rate mean. So response rate for clinical trials is generally standardized across all tumors. And so it's based on a percentage change of the tumors that you see at the start of treatment. And now if you go back to our discussions about how challenging it can be to see and track uveal melanoma, we'll discuss on some of the TEBI data that we're not sure if response rate is the most helpful way to follow uveal melanoma progress. Because you definitely need an MRI, but it can be tricky to really capture how much benefit you're getting in some of these smaller tumors, because just because you aren't having significant shrinkage of those tumors, if we're keeping things stable without growing, and I like to encourage patients, like that's still a good outcome with the medication, because for the most part, patients with uveal melanoma, if you're diagnosed with metastatic disease on surveillance, you feel good, right? You may not have symptoms from your cancer at that time. So even if we can keep your disease from growing, that can still be beneficial. And so that's where the response rate can be challenging. And we'll discuss in the next session with TEBI that even though we see a low response rate, we'd like for that to be higher, we still saw that medication was helping patients live longer, which is ultimately what we want and shoot for.
Okay, I think that's a really good important point to make, because I think that can be scary, right? To look at the response rate and see it's so low and to wonder like, well, does it even work? So let's definitely talk more about that later. I think for this final question, before we close out this session, this one I think is just in general good for understanding, and I think it would be good to have some clarification here, because I think that this can be, and I've discussed this with Dr. Moser, but this can be one of those areas that you guys see patients and they tend to, it can go either way and it can be a little unknown. So this is two questions that talk about, okay, are there alternative therapies that you guys discuss with patients? And how do you navigate that with a patient who is wanting to pursue, Eastern medicine, alternative therapies, how do you keep the lines of communication open? And Dr. Moser, if it's okay with you, can I pose this to you since we just talked about this in our recent discussion earlier this week?
Yeah, absolutely. So, I think there's kind of two answers I give depending on the situation. So if a patient's going on a standard treatment like, nivolumab and ipilimumab or Tebi, then I tend to tell them, do whatever you want alongside it. Just let us know. Most of these alternative medicines, we don't have perfect information on side effects. And so 90% of the time I'll say, well, we don't know if it's going to interact, so just let us know if anything happens. But there are certain instances where we do know that things interact. So we just need to make sure we know what you're on. That way we can make sure there isn't a known side effect. The thing I always tell people about that, though, is my clinic, just like Dr. McKean's clinic, just like everyone else's clinic, we have insurance teams that get authorization because we never want you to lose your house or become bankrupt from the treatments we're giving. So just make sure if you're seeing an alternative medicine doctor, they're doing that as well or being cost conscious. There's really nothing more heartbreaking than seeing a patient who goes to another country to try to on alternative medicine and comes back and is now broke and no longer has a house, right? That's just heartbreaking, and we don't want that for our patients. If patients are on clinical trials, because of the safety and regulation of the clinical trials, there's a lot more rules about what you can be on. And so depending on the clinical trial, they may restrict any alternative therapies. Some may be okay. But on clinical trial, it becomes more of an issue just because we have to make sure that it's in the protocol in terms of what can or cannot be done. But in general, I'm supportive of alternative therapies as long as there's not a known toxicity or side effect, and that includes significant financial toxicity.
Dr. McKean, do you want to weigh in on that at all, or did you feel like that covered it?
Yeah, no, I think that pretty much covers it. I think one thing I'll discuss with patients is that if you are going to try some alternative therapies, to keep in mind that we keep coming back to the liver, right? Keeping the liver healthy, happy is the most important thing, but the liver is where a lot of drugs are metabolized, and so we just have to make sure that these medications aren't affecting the liver and causing any inflammation, whether that's short or long term. And so I think just having that open conversation with your doctor so we can be able to check your labs and watch carefully is really important.
Yeah, I think that's probably the most important thing, right, is just keep the line of communication open. Okay, I feel like that covers what we need to in this session, unless you guys have anything you want to wrap up with. But Dr. Moser, Dr. McKean, Dr. Sanger, thank you so much. This discussion was wonderful, and just like I said, keep in mind, I did get a lot of questions. Some of them I sorted, and they are more pertinent to the Castle testing discussion we're going to have later today. Some of them are very KIMTRAC focused. We'll discuss those later. So just keep in mind, if I didn't get to your question, I'm not ignoring you. We just had a lot of questions, and we've got to kind of sort through and make sure they're appropriately sorted. So we're going to excuse you guys for a break, and we're going to have Dr. McKean back again with Dr. Moser to present further on KIMTRAC.